welcome back to World Health SocialGood and the second day of the World Health Assembly in Geneva, Switzerland. I'm Christy Feig, the Director of Communications here at the World Health Organization, and I'll be your guide as we move forward throughout the week. Now, we're set up here in the heart of the Palais, and we do that for a reason, so that we can grab the experts as they're walking by, so that you can have time to ask questions to some of the top experts that are here at the World Health Assembly. This year, we're also broadcasting live on the web, and you can find the webcast on who.int. You just click on the webcast for the World Health Assembly, and you can choose the plenary, Committee A, or Committee B. Now, yesterday was about formalities here at the World Health Assembly. We had the German Chancellor who came and talked about, kicked open the Assembly with her opening address. She talked about Ebola and what the organization needs to move forward with. She talked about AMR, and she talked about other health focus for the G7, of which Germany is now the president. Then we had the Director General of the World Health Organization, Dr. Margaret Chan, and she also picked up on those themes as well. She talked about the 5 things that the organization would do to move forward in reforming the organization to respond better to future emergencies like the Ebola outbreak was. She also echoed the importance of antimicrobial resistance, which is AMR. Today we had Committee A get into high gear. This morning they took up with malaria, then they went to dengue, then we had the start of the conversation on the Global Vaccine Action Plan. Then we had a technical briefing. Remember, we talked about those yesterday, and that was on Ebola, and we had representatives from the 3 intensely affected Ebola countries there. Then we moved forward at 2:30 into the Ebola session, and that's why today we are not going to have the experts from the technical briefing. That will be tomorrow, because all of the Ebola experts are in Committee A working hard. Today we're going to talk about some other very big topics here at the World Health Assembly. We're going to talk about air pollution. We're going to talk about how WHO works in emergencies, nutrition, and the idea of setting core indicators so that we can measure progress in nutrition. And we'll also be talking about mental health in emergencies, something very important, and we've got some excellent people here. So, here we go, air pollution. One of the big topics that will be happening for the next 6 months, I would say. Joining me, Dr. Maria Nero. You'll remember her from the Rapid Roundtable yesterday. She's back to go deeper with us today. So get ready to submit your questions at hashtag WHA68 and hashtag SocialGood. Maria, talk to me about air pollution and health, but first, before we go to the big climate summit in Paris, let's talk about the issue of air pollution so that everybody is caught up to the same place. Obviously, when there's a lot of air pollution outside, it makes it hard for us to be active. It makes it hard to breathe, but it's more than that, isn't it? It certainly has an impact on the health aspects of us. Can you explain that to us, what's happening?
Yes, it's certainly more than that, Christy. It's so serious as it's responsible for more than 7 million deaths every year. Can you believe it? So when you are exposed to different sources of air pollutants, this will result in more than 7 million deaths every year. Means 1 death every 8 in the world each year. Premature deaths that can be avoided if we take the right decision. That's why we are saying that all of those diseases caused by exposure to air pollution, like lung cancer, obstructive chronic pulmonary diseases, or asthma or pneumonia, but as well cardiovascular diseases, which is the new thing, the new knowledge we have, and representing a major challenge for our society.
Now, we mentioned it yesterday, but I'd like you to touch on it again today. What is happening this week here at the World Health Assembly with air pollution? There's some major work going on.
First of all, we have on Wednesday a technical briefing on climate change and health. And what we are saying, one of the things we are saying during the technical briefing is that if you tackle the root causes of air pollution, in fact, you are contributing to reduce air pollutants and therefore contributing to reduce those 7 million deaths that are occurring every year and that are linked to the exposure of air pollution. But then, most importantly, is that for the first time in WHO, member states are discussing a resolution which, in my opinion, is very ambitious and definitely looking at the root causes of diseases and not just the diseases, which is a resolution on air quality and health. The member states are recognizing the importance of addressing this major public health issue, probably the biggest we have in front of us at the moment, and therefore they are recommending WHO to take more action, and they are recommending as well member states to take different interventions at country level to reduce this major challenge for our health.
What kind of interventions are they suggesting?
Well, actually, what we need to do is to put the scientific evidence on the table. That's the first thing. And this is what WHO did on linking diseases to the risk factor represented by air pollution. We identify the air pollutants that are bad for our health. We set up standards for them. Many countries are now saying, according to WHO standards, this city is going above the recommended levels, and therefore it's bad for your health. And that's good as well to disseminate that information, because citizens are aware of that, and they are putting a lot of pressure on their politicians for them to take action. More action is to monitor the quality of the air we breathe, then obviously to propose interventions to reduce that air pollution, like better and more sustainable public transport system at the city level, energy efficiency in our homes when we heat or we cold our houses, better industrial processes where we filter and we are not contributing to the emissions, agricultural policies, plenty of interventions that will be very beneficial for the environment, but more importantly, there will be extremely beneficial for human health.
I bet a lot of you didn't realize that WHO sets those air quality standards on whether or not the air is actually going to do damage to your health. Let me ask you one other question. Air pollution is a really good example to use for the challenges in health these days. It's not health in a silo anymore, is it? Health really cuts across, and when you're trying to reduce air pollution in a country, the government really has to look at many different aspects of this. I mean, it affects not only the health sector, it affects trade, it affects economic aspects, it affects many different things. Talk about the challenges for a government to navigate some of those.
It's fascinating because, in fact, people understand when we talk about diseases, and then we say we need to control this disease. But when it is about the causes of those diseases, then you enter on the way the society live, the way you develop your urban planning, the way you transport, the way you consume, and the way you will have your industrial production, and the way you consume energy, everything. This is the most fascinating part of public health. We are not just here to treat diseases, which is an important part, but most importantly, we are here to influence choices, societal choices, to make sure that we select those that will be contributing more to health. It's difficult. I'm not telling you that it's not difficult. It's very difficult. You need to convince the Ministry of Energy, you need to work with the Ministry of Environment, Agriculture, Finance, and you need to empower the Ministry of Health for him or her to have the right arguments to change and make sure that we have health in all policies. And you convert every minister on a Minister of Health.
If it was easy, it wouldn't be a problem today, right?
Exactly.
That's right. Listen, these green circles here mean that we have a question from Twitter. So let me tie two things together here. In December, there was a major climate summit that everybody's getting ready for. The question that comes from Twitter is, how seriously does climate change affect air pollution?
Well, the thing is, the causes of climate change are very much related to the causes of air pollution, which means that if you take the right decisions on reducing greenhouse gases emissions, you will need to have a better public transport system and reduce the reliance on your private car, and then reducing emissions caused by vehicles. You need to have a more sustainable and better access to clean energy. All of those measures that you need to take to promote a sustainable development and an environment which is very friendly, those are public health measures. So by doing so, you will be contributing enormously to reduce air pollution and therefore to reduce those 7 million deaths that are a major problem for us.
It's an enormous number, and it really shows that it's something that everybody's going to have to give a little bit into if we're going to get where we
Absolutely.
need to be. Maria, thank you for coming by.
My pleasure.
Maria is somebody who's not going to get a break the next 6 months, that's for sure. A lot of work to do before the conference in December. Thanks for stopping by, Maria.
Thank you.
All right, now we're going to move from one complex area of work into another complex area of work. We're going to talk about how WHO works in emergencies. Now, you're hearing a lot at this assembly about how WHO needs to make some changes in order to work better in large-scale disease outbreaks like Ebola. But WHO is already, even as we're speaking, working in some very major conflicts and emergencies. And I know you can't see me through Kareem, but wanted to talk to some of them. It's good to see you again. Yes. We wanted to talk about some of the work that's going on right now in emergencies and how the organization is working on the ground there. Joining me, back by popular demand, Dr. Elizabeth Hoff, our head of country office in Syria and one of our most popular people from last year. Dr. Michelle Gaia, who is the acting director of Emergency Risk Management and Humanitarian Response, which is a very complicated way of saying she is overseeing all of our emergency work at this point in time. And Kareem Abdel Tawab. He is a young leader from Egypt who is a medical student and is working on humanitarian action in a very important area of humanitarian action right now. Now, Michelle, let me start with you. Today, there are major emergencies going on. Now, at WHO, we divide emergencies by grades, 1, 2, or 3. 3 being the highest, the biggest response needed, and that pulls on all aspects of the organization. So it is considered a very major response if it's a level 3. How many of those grade 3 emergencies would you say that WHO is responding to today, and what are they?
Right now we have 6 grade 3 emergencies. We had 7 when the Philippines typhoon happened, but right now we have obviously the major response to the Ebola outbreak in West Africa. We have the response to the Nepal earthquake, which happened quite recently. And then we have 4 other grade 3 emergencies, which are long-term, large-scale conflict situations, and they are Syria, Iraq, Central African Republic, and the crisis in South Sudan.
Give me an overview here. How does WHO work in these emergencies? What is it that we're due?
Okay, look, let's, before we get to these emergencies, we take a step back. WHO actually works with all our countries before an emergency even starts. And we work with them to prepare them for any kind of event, whether it's a natural disaster such as an earthquake or a typhoon, or whether it's to deal with a conflict like in the Syrian Arab Republic. So our role is to really help the countries to be able to prepare themselves in case something happens. Because if you think about Nepal, who is the first responder?
That's right.
Not us. It's the community that is responding first. Who detects an outbreak first? Not us. It's the individual that notices something wrong and then goes and seeks help, and that person at a healthcare facility might get tweaked to an idea. So really our role is to prepare those countries to be able to get that response going first. Now, what do we do when a response actually happens? There are many things, but on the whole, in terms of a disease outbreak, we are trying to help to put in control measures to contain the outbreak, whatever they are. And for a different type of outbreak, there will be different things that will put into place. It might be water and sanitation, it might be burying bodies properly, as in with Ebola. For natural disasters and humanitarian emergencies that are caused by conflict, our role is really to make sure that we provide people with basic health care that they need, and to help prevent any further disease. So, for example, if you need to seek health care for injuries because of conflict or because of the earthquake, you need to be able to go to a hospital. If the hospital is damaged, we try and support bringing in different foreign medical teams to support the delivery of those services. If you need a cesarean, it doesn't matter whether it's just had an earthquake or there's conflict going on, you'll still need to deliver a baby. How do you access that service safely? How do children get vaccinated? So our role is to make sure all of this is still going on. The most important thing is to make sure that people's lives are saved, regardless of what is going on, but to do it fairly so that people who are in need are able to get those services fairly. One of our biggest roles actually in that case is the coordination. Many people come to help, as you know, in these situations. Not so many people come to help in conflict. They certainly come to help a lot when there's a natural disaster, but our role is the same. We coordinate the partners that come in. In Nepal right now we're coordinating over 100 partners, for example. and Elizabeth will talk about the coordination at the country level in Syria, we need to make sure that we don't duplicate efforts. So in one area, you don't want everyone to be providing primary health care. You want surgery and maternal care and reproductive health, mental health. So that package, and that's where our role is very strong. Our final role really, what we, World Health Assembly, we're a technical agency. We want to make sure that the standards are correct. What are we doing? Is it of good quality or not? We're not going there to experiment. These are human beings, and they need to be given the quality of care that we provide to our own populations anywhere else.
Really useful way of explaining what we as an organization do, and I remember even hearing about hospitals that did not collapse when an earthquake happened because we had worked with the government to help retrofit them before, because we knew that they lived on a fault line and we knew this was a high risk. So it really pays off in the long run. Let me ask you one last question. Some of these emergencies, for example, Central Africa Republic, they fall off the radar screen when the media leave, and it's not such a hot issue and it's not constantly in the media spotlight. How challenging is it for you and your teams to get the resources they need in emergencies like that when the media is gone and the work has got to continue?
I would say extremely challenging, and we are less than 20% funded for this year, as for many of these chronic emergencies, because the attention goes away. And let me say that these countries have long-term effects on health of the population. So this is not just after a few weeks. Years and years and years of poor child health, poor maternal health means that, for example, in 7 out of the 10 countries where we have emergencies, there is the highest child mortality rate. In 6 out of the 10 countries where we're working that have emergencies, has the highest maternal mortality rate. So these are not acute emergency countries with earthquakes. These are ones with chronic, long-term protracted emergencies. So if we let the attention die off these countries like Central African Republic, we're never going to reach the global goals that we want to improve the lives of people and attain these goals in terms of under 5 mortality and maternal mortality. So it's a huge challenge, and we keep working in them whilst the attention goes away. As I said, WHO is we're there before, during, after emergencies. And that is one thing that I think we should really highlight to the world.
Yeah, absolutely. One emergency I would say that's hardly forgotten but is absolutely heartbreaking is the one you work in and day out. Elizabeth is our head of office in Syria, and you've been there for what, three and a half years now? Yes. Absolutely tireless at her work. Elizabeth, kind of put an on-the-ground perspective here for me on what Michelle's been talking about. What is your daily work there working to achieve?
Well, we are now in the 5th year of the crisis in Syria, and there has been no stop to the violence. We have approximately 25,000 injured per month. And
per month?
This is, yeah,
Did
per month.
you say per month?
Yes. And when we put this into perspective to the other crisis, then we have to really look at the seriousness of what we are talking about. We have more than 7 million internally displaced in Syria. And where do they go? They go to where they can find some safety. And many of them are on the go, not for the first time, that they move from the rural Aleppo into Aleppo town. But now that has also become unsafe, so they are trying to move to Hama or to Latakia. But this is the everyday life for more than 7 million. And on top of that, we have more than 4 million Syrians who have left the country over these 4 years. So this is the struggle they are faced with. And what you can see is that the population, they don't really ask for the reason for the conflict and political constraints. Where should we go? They are more like animals. They are seeking, where do I find safe water? Where do I find care? Where do I find protection and shelter? So this is where they are moving. They are not asking, about conflict lines. The only thing they are asking for in this kind of emergency is some kind of safety for themselves and for their children. And what I would like to see is that they can find health care and also education for their children where they will settle down for some time. And when we talk about who is actually responding to this emergency, I would like to follow up on what Michelle was just saying. As the UN, NGOs, communities, but really in Syria it is like another emergency, the Syrian people who are actually taking care of the people. Most of these internally displaced are actually hosted by the Syrian families. But unfortunately, after more than 4 years of conflict, their coping mechanisms are exhausted. So this is where we are seeing that almost all the families in Syria today are affected. They are struggling with anxiety, with grief, having problem of finding health care. More than 50% of the hospitals have been now damaged or are partly out of service. And 40% of the primary healthcare services are no longer functioning. So what we are hearing is that many patients in acute need of care, they are traveling 160 kilometers to find primary healthcare services in many of the areas. And what Michelle was referring to, also for example, women who are in labor, they are so afraid because how can they make sure that they can travel at night? Because you don't know when is the onset of the labor. So will it be safe for them to travel? They have to pass many checkpoints. So while before, all the deliveries were in institutions, hardly any maternal mortality in Syria. They had the best health indicators in the region throughout for maternal and child mortality. Unfortunately, this is no longer the case. We have a drop in the vaccination rate from 92% before the conflict started to around 50% today. And we have had outbreak of polio. And we are seeing measles, we have waterborne diseases. You know, in these shelters where the people reside, between 50 and 70 people are sharing one toilet. So then you can understand that there is really diseases on the rise. And we have difficulties with making sure that when we are delivering protective, preventive messages, you know, that how can they access water to wash their hands? Many of them have water 3 hours every 3 days. So you can see the constraints that many of the people are facing.
You know, I was going to ask what some of the health impacts were, and I think you have just summed it up beautifully. It's really hard to imagine that. I want to ask one last question for you. How, as an organization, do you and your team manage to get the supplies, the equipment, the materials that you're moved around in a place that is that difficult?
Access is the main challenge. But I would like to say that WHO has a very good credibility in the Middle East and also in Syria. And this has helped us enormously when I came in 3 years ago. To build on this credibility, the trust, and to keep up a very transparent and frank dialogue with the authorities, whether it is at the central level or at the local level, to negotiate access. But we have today more than 4 million people living in hard-to-reach and besieged areas. And this is what we are facing is really to make sure, and it is not enough. So I think that the UN in general had done a fantastic job with opening up for cross-border and also to strengthen cross-line deliveries so that we can cater for these needs. But for WHO it is also not only to think about sort of the people in the besieged areas, but also all the people who are actually staying in shelters and in need, because as I was saying, every family is affected, so we have to strengthen the services throughout the country to make sure that we have medicines that we can deliver. Also mental health services is very important. 50% of the population is suffering today from mental distress and psychosocial distress. So this is what we need to do. And we have actually a multi-pronged approach as WHO. We have identified very clearly our intervention areas. We are focusing on primary health care, including mental health, and we are also strengthening the referral services for secondary care. So we see that what we are doing is paying off. We have gotten good donor support. We need, of course, more to do more. But what I would like to say is that we can say that we are delivering. Last year we delivered more than 14 million medical treatments. So far this year we have delivered more than 8 million treatments. And we are receiving very positive feedback from the Syrian people because we are impartial in our work. Equity and fair delivery is really what matters. Every Syrian should have access to good health care to the extent possible.
I'm going to ask you a question that just came in on Twitter here, and that is what strategies are being discussed to improve that access to health care for the people who are displaced, which you were just talking about?
Yeah, I would just give an example. I was recently in Latakia Governorate, which is one of the safer areas. They had received, before the attack on Idlib, more than 1 million internally displaced. They have an influx of an additional few 100,000, and this is a population of 1 million. So, of course, their services, which they normally had, is totally overstretched. So what we are trying to set up is also with mobile teams, health teams, to go to visit in the shelters, in the homes, to help out, to make sure that we have supported with mobile clinics, sort of ambulances, almost like buses, where we drive into the neighborhood so we can reach them. And this is for the internally displaced, and we are trying to do the same in hard-to-reach areas. But what we are trying to do is really to focus on the essential, that we cover vaccination, that we are covering antenatal, delivery and postpartum care, following up on children under 5, and making sure we reach the people where they are with the services.
Elizabeth, I'm going to ask you to come back a little bit later in the show. I have a segment talking about mental health care in emergencies. I'd like you to stick around if you don't mind and join us for that discussion as well. Michelle, let me come back to you for just a moment. What would you say on a bigger picture are some of the biggest challenges that you and your team face working in emergencies?
Christy, right now we're dealing with emergencies on an unprecedented scale. So I mentioned the 6 grade 3 emergencies, but right now we're responding to over 30 emergencies in total as WHO. But the fact is that they are so large, they're affecting such large populations. They're complex because there's conflict, and they're of long duration, and the scale is enormous, not just in terms of geography as well. And so in terms of these challenges that we face, to be able to access, as Elizabeth was saying, remote areas, areas that are fraught with insecurity, our biggest challenge is to be able to get to the people. And we have to think of all these innovative mechanisms and approaches to reach them. But remember, we have to protect our own staff as well. So working in these difficult operational contexts is high risk. And this is one of the huge challenges of the organization, to make sure that our staff are safe, that our partners that we work with closely are safe, to be able to go and deliver the basic services to this population. And it's a highly difficult environment. We're not negotiators, but sometimes we have to negotiate with people. We're health people, we're doctors, we're nurses, community workers. We have to negotiate with people to get access. And I think that's some of the biggest challenges operationally. We have to set up sub-offices in very difficult locations. We have at least 5 in Iraq. We have 3, soon to be 5 in Central African Republic. We're not just working from a remote basis. We're actually out there trying to be right amongst the population. But the final point I'd like to raise is, we have never seen such a level of attack on healthcare. It's unprecedented. It's as if international humanitarian law doesn't exist. There is no neutrality of the healthcare system. So healthcare facilities are bombed, healthcare workers are attacked, kidnapped, ambulances are sieged. This is not normal. We should have a space to be able to provide aid because we are neutral and we want to be fair. And no one is obeying this. And I think this is one of our major challenges.
I think that's a perfect setup for Karim here. Karim from Alexandria in Egypt, and working on as a medical career, and you're particularly engaged in this. You've had some experience with this. Tell me about your experience.
Yes, so in Egypt, as a medical student, we have working in the International Federation for Medical Student Associations. In our general assemblies, we had, and in our regional meetings also, we set up in collaboration with the International Committee for Red Cross and Crescent and the Egyptian Red Crescent. We work together on a project called Healthcare in Danger, where we educated the medical students and also parts of healthcare providers, pharmacists and nurses and others, on how safe access to conflict zones, first aid and safe exit, which were very important. What we did is that in collaboration with the ICRC and the Egyptian Red Crescent, we set up this big simulation in Egypt. It was in Cairo. There were actors, there were people, actors for pretending to be victims, families, so that the medical students can undergo the pressure that is put on them from the families of the victims and the casualties. And it was really successful. Participants came out, they know now how to act in conflict zones. They can participate whenever there's a riot, whenever there's war, whenever there is any disaster or conflict that may arise in the country. And what's good is that it was done in Egypt, but there were many participants also from across the region. So we had participants from Morocco, we had participants from Tunisia, Lebanon, and other countries in the Gulf region.
You know, and it's really that type of work, I think, that's going to have to build the grassroots and the momentum.
Absolutely.
And the pressure for building that respect for the international humanitarian law, as you said. We're going to have to stop it there. I think we could probably talk for another hour or two with you three. But really, whenever you think you're having a rough day, think of the three people sitting at this table. My goodness, you have... Yes,
absolutely, yes.
You have quite a job to do, and I thank you all for doing it.
Thank you, Chris.
You stay close, but you can take a break for just a moment. Michelle and Kareem, thank you so much for joining us. In a little bit, as we were just mentioning, we will come back and talk about the mental health issues in emergencies, because really that type of exposure constantly to traumatic events puts an impact that goes deeper than just a surface. And it really needs a lot more focus in this show, and we'll certainly do that. But first, let me just check in on the digital side of things, the media side of things. We have with us Sari Setiogi, who is the head of our social media team, and she comes by every day just to give us an update on what people are talking about on social media and where the excitement is. And we have a journalist with us every day. We have the UN Foundation Journalism Fellows who have come to cover the World Health Assembly, and we'll be catching up with them. Sorry, let me start with you. What has your team been working on today?
Thanks, Christy. So today we're trying more on Periscope, which is a live broadcast app, because the whole World Health Assembly is being webcasted. So we think that we want to cover also the behind the scenes activities that are not covered by the webcast. So today, for example, we do a live broadcast for the how to put on and off personal protective equipment, or PPE, and that was quite popular for about probably 6-7 minutes. We got about over 200 live viewers. So we will try to keep doing this throughout the week with different activities that we spot during the Health Assembly.
Very good. Our journalist is Kaylin Hogan from the Ground Truth Project. If I remember correctly, you're also with Kaiser Family Foundation Fellow? All right, good. Tell me about your experience here at the World Health Assembly. This is the first time you've come, right?
Yep.
You have to give up your microphone, sorry.
Sorry, I'll steal that from you. Yes, first time in Geneva and first time at the WHA, and it's been some experience. It feels like a week already.
Thank you for saying that.
It's been very hectic, but very informative. We were at the Ebola briefing, the technical briefing this afternoon, which was, a real insight into where the 3 worst affected countries are at the moment. The DG and Bruce Alward really stressed that, this epidemic is not over, even though Liberia is, finally at 0 cases. And we heard a lot from Liberia about how they got there, and great to see the cooperation between the 3 nations. The fact that Liberia, was adamant that this epidemic is not over until their neighboring countries are also Ebola-free.
Yeah, that's right. Let me go back to Sari for just a moment. Sari, for the first time this year, the Assembly is being webcast, and we have an app for the first time. Tell people how they can track what's going on here, though, because you're still covering on Twitter the resolutions as they're approved. Tell people how they can keep up with us.
Yeah, so for the app itself, they can download it on iTunes store. And also they can still follow us on Twitter at WHO, hashtag WHA68, and also on Facebook where we post quite a lot of photos. It's facebook.com /World Health /WHO, sorry. Instagram at World Health Organization, and also Periscope that I mentioned earlier. You can find us at WHO on Periscope.
Very good. Thank you both for coming by. Appreciate it. All right, the breadth of topics that we're going through today really reflect the level of work that's going on here today. We started in Committee A with some communicable diseases. We started with malaria, and that will be continued later in the week. Then we went to dengue, and now we've gone to Ebola in Committee A. And so it's covered an enormous ground of work, and it just continues. I'm looking at the agenda here for this show, and it really reflects the vast spectrum of topics that we're going through. We're going to turn our attention to one that cuts across to many different aspects of our lives. It's nutrition. And I've got with me Dr. Francesca Bronca, who oversees our nutrition work at WHO. This year, the World Health Assembly is taking up the issue of developing a core set of indicators for maternal, infant, and child nutrition. Why is that? Why is that useful? Why do we need that?
Hello. First of all, we need to know that addressing the health and nutrition of children is going to be very important for a country's development. We calculate that there is about 200 million children who are not reaching their full development potential. And that's a big deal, because simply addressing stunting would be improving the gross domestic product by 3%. If we improve the anemia of women, we could get the productivity of adults improve up to 17%. So major impact. And this can be achieved by simple, cheap investment. And we calculated for every dollar invested in nutrition, there would be a return of $18, which is, much more than any investment you can expect if you work on stock exchange.
It really is one of these things that a little bit of investment raises the tide for all ships, isn't it? There's some ambitious goals that have been set for 2025, right?
Yeah, that's correct. The World Health Assembly realized that nutrition is so important that you need to set goals. And they set goals in 2012 for 2025 for a 13 years sustained action in nutrition. And these goals are for child nutrition, to get children growing in the right way, so a reduction of stunting, to get children well nourished without acute malnutrition, so targets on wasting, to avoid them to become overweight, which is now a problem more and more for lower income countries, to stop the epidemic of overweight, to get adequate breastfeeding rates, to get lower children with low birth weight, and to get less women with anemia. So these are the 6 global targets that WHO set, and unfortunately I must say the world is not on track to reach them.
Can you talk about some of the challenges of why we're not on track? What are some of the challenges that you're faced often with in trying to address this problem, and what does that mean for the post-2015 development goals?
We're not on track, although we're having some progress, because the challenge is in different sectors. We need to provide, first of all, a good food environment, and that has to happen throughout the lifestyle. We say that we need really to start from the first 1,000 days. We need already to have adolescent women having a good nutrition so that they're ready when they bear a child to have a good pregnancy. So that food environment is still a challenge, and unfortunately there are contrasting interests and there is policy incoherence, and so that goal is somehow difficult to achieve. Then we want to see that effective nutrition interventions are delivered to all children and women. We know what these interventions are, but unfortunately the coverage is still very low. So we need a greater investment there. We need better governance, we need better commitment of policymakers to make this happen.
You know, you mentioned just a moment ago the issue of overweight, but there's also the issue of hunger. How do you run these parallel tracks like this? How do you reconcile trying to address hunger issues and trying to address overweight issues?
Well, they're actually parts of the same problem. We have what we call a double burden of malnutrition in many countries. Look at South Africa, for example. You have an incredible number of women who are overweight or obese, over 40%. And still you have about 10% of women who are underweight. And this is in the same country. Often in the same community you have people who have, in the same family even, you have individuals with overweight and people who have, for example, vitamin and mineral deficiency. And the common pathway is the fact that actually the food environment is poor, so people don't get enough access to the right healthy food throughout the year because they can't afford it, or because simply it's not distributed, because what gets distributed is maybe products which are, giving a greater return to the manufacturers but not necessarily healthy. So these are the common pathways, but also, the poor environment. And this is unfortunately the common aspect is often poverty. So people living in poor neighborhoods with not good water and sanitation, they're also getting the malnutrition. So maybe you get too much energy, but the quality of the diet and the risk of getting malnutrition is high.
Well, Francesco, I'm going to let you go at that point because I know you've got a lot of work ahead of you this week. Thank you for coming by and at least introducing us to this topic, and I'm sure we'll talk more with you as progress happens this week at the World Health Assembly.
Thank you very much.
Thank you. Now, just a moment ago, we were talking to Elizabeth Hoff, who is our head of country office in Syria, and she mentioned something that really connected to another topic that we're going to take up here, and this is the issue of working in mental health, trying to address mental health issues in emergencies, whether it's natural disasters, conflict, or other emergencies. It's a real problem. Worldwide, close to 80 million people are currently impacted by humanitarian emergencies. And as you heard earlier, one of the first things we do is get in the basic first aid, get in the surgical kits, get in the trauma kits. But really, it doesn't take long for people to realize that the injuries and the damage goes much deeper in somebody. And going through natural disasters really does a psychological impact as well. And joining me to talk about what WHO is doing to help address this is Dr. Shekhar Saxena, who is the head of our mental health and substance abuse program. And of course, Elizabeth has come back to join us. Shekhar, let me start with you. Just a few weeks ago, in fact, it was shortly after the earthquake in Nepal happened, we put out guidance to help health workers who are working in emergencies address mental health psychological issues, even if they weren't necessarily trained in that area of work. Can you talk a little bit about this guide and bring our viewers up to speed on it?
Thank you, Christy. And you're right. A number of people face psychological problems and social problems. And unfortunately, some of these countries which did not have good expertise on mental health in any case are now having larger needs and decreased capacity. So WHO has given some guidance and actually an instrument by which the usual humanitarian workers and health workers can actually be trained very quickly to provide the kind of psychosocial help that is necessary for the populations. And this can be done quickly, this can be done efficiently, and goes a long way actually in providing help to people who need it now.
Can you talk about what are the most common types of mental health issues that you see in emergencies?
I'm sure everybody has heard about the post-traumatic stress disorder, but I just want to clarify that that's only one of the conditions that comes up. Much more common are the usual depression, the anxiety, as well as some of the other more severe disorders, including psychoses, a recurrence of epilepsy, and many other conditions. So the burden is large, and the numbers of people affected is extremely large.
And why is that such a high priority in emergencies? What does addressing that enable us to do broader in emergencies?
We always say there is no health without mental health, and this applies equally well to emergency situations. But what is really important is to say that if you look after the psychosocial and mental health of people who have just undergone some very severe stress, you actually help not only them, but you also help the other health spheres. They look after their health better. They actually can recuperate better. They look after the economy better because they can be employed. They can actually lead to productive life of themselves and communities. So it's a method by which you help people to look after themselves and the country better. So it has double advantage.
Thank you. Elizabeth, let me come to you. Just a moment ago, you were mentioning what a big issue this is in Syria, where you work regularly. Yes. Talk about what you see there on the ground. I can only imagine the traumatic events that people have lived through. Well, what do you see? Elaborate on what you were saying earlier.
What we see and what we hear is quite clearly that every family is affected. They have serious problems with anxiety and grief because most of them have lost one family members or have someone injured or have sent their son or as the daughter as a volunteer to try to help in a community where there is insecurity and violence going on. So living with violence under these difficult circumstances is affecting more than half of the population where they really have mental problems in terms of depression and anxiety. And on top of that, we have today in Syria around 600,000 with severe mental disorders, which has also increased from before, where it used to be in 1 to 2% of the population. Today it is like 3 to 4%. And there are also some good aspects of the crisis, which is that before, mental health problems were very much stigmatized and mental health institutions were separate from the normal treatment where you had physical illnesses. But what is happening today is that WHO has been able to actually promote with the Ministry of Health a different approach, also with the local health authorities. So we have already started and we have actually rehabilitated 2 units in the normal hospitals, if you would like, when I say normal, with physical care, so that there is no difference between mental care and the physical rehabilitation that is required. So this has been a good thing. We have also rehabilitated outpatient clinics. In the beginning of the crisis, we focused very much on the psychosocial support aspects, and the social aspect was working very well, but we didn't really have any place to refer those who had problems with their mental health. And this is what we have focused on. So with these guidelines that has been produced by WHO, the GAP, mental health GAP guidelines, we started to train and sensitize the physicians working in Syria to mental health problems and how to treat the patients when they had these conditions referred to them. And the good thing is that we have trained now more than 600. This is not enough, but we are focusing on it, and we are receiving support from headquarters, from my colleague here on my right side, and also from the experts from the regional office. And we have also started to train psychologists. So we have 36 we have trained, small scale, but we hope to see this. But the most important thing that we are focusing on is to get it out from the central level and down to be community-based, so that we can meet the people where they are and talk about the problems that way they have. And I can just tell you that I met a woman who was thanking me very much for the community care, because the son had been referred. He hadn't slept that he had been injured he hadn't slept for 3 weeks because he was actually disturbed by the pictures that he saw in his head after that. He got good treatment for his physical care, but he needed really rest and care for his depression. And this had been difficult to find even before the crisis in Syria. But now this is something we are focusing on, is to try to help the individuals with their problems that they have. And we see that half of the population actually needs somebody to talk to, they need proper care, they need sort of also medication for their anxiety, and this is what we are trying to establish.
It's really the perfect illustration of how a guide like this is so useful in our work in the field. It's always nice to have you with us, Elizabeth, and it always amazes me that somebody that works in such a constantly stressful place in a situation looks so refreshed and rested every time I see you here. Thank you for coming by, and thank you for what you do.
Me. Thank you.
Shekhar, you can sit tight for just a second, Elizabeth, but Shekhar, I want to keep you for just a second because there's a resolution here this week. And you know, the way that we're set up here in the middle of the Palais means that we can snag anybody that comes by and ask him anything we want to ask about what's happening at the World Health Assembly. So if I could ask you about the epilepsy resolution, is that okay?
Yes.
All right, terrific.
But Christine, let me just say a word about the guidance that we provided. This is done by WHO and UNHCR. So actually there are two international organizations behind that, which actually increases the quality and also the scope of its application.
Absolutely, and they are certainly major partners working in many of these emergencies. So yes, that's a very good point to bring up, UNHCR. All right, let me talk about epilepsy for just a moment before I lose you. More than 50 million people around the world, if I have my numbers right, have epilepsy. More than 3/4 of those living in low and middle income countries. What is the resolution that's on deck this week trying to achieve?
This World Health Assembly is discussing epilepsy as a disease. It's putting it higher on the public health agenda, and it's specifying the kinds of actions that countries need to take and the kind of actions that WHO needs to take. It essentially covers giving epilepsy a higher billing on the country's agendas, strengthening governance, making essential medicines available to people, and training primary care providers in providing the kind of treatment that people with epilepsy need. You mentioned 50 million. Most of them live in low and middle income countries, and they need help now. And unfortunately, that help can be given by the general doctors and nurses. They don't need to go to the specialist. 85% of people with epilepsy can be treated with proper training and availability of drugs by the doctors and nurses who are right there in primary care. And I'm very happy to note that this resolution is proposed by China, which has actually a very large amount of experience in this. We have worked with them for the last 20 years. And the story of China for epilepsy is an example to be taken by all countries. And this is something that we're looking forward to, having this resolution and then assisting countries in treating people with epilepsy and changing their lives by this treatment.
Looking forward, I mean, really this has been quite useful to help us understand that dealing with mental health issues actually really is vital for moving forward health in general. What other major issues looking forward would you say there are in mental health that we're planning to start addressing? What's on the horizon?
Well, I'm happy to note that there is so much interest on mental health because this has often been ignored in the public health agenda. We also have a progress report on the mental health action plan that was passed by the Assembly in 2013, and we are reporting how well or sometimes how not so well countries are doing. One of the issues is suicide. You know that mental health action plan has an indicator on suicide rate, and we published just last September the World Suicide Report, and we're very happy to note that a number of countries are establishing their suicide prevention strategies and making very good attempts in preventing suicides in their countries. I must say that no rate is acceptable. No suicide is acceptable. Any rate is too high. So all countries, whether they have a high rate or low rate, need to take steps towards preventing suicides, and they're doing it.
That was one of the most important reports we had last year. Quite useful. Listen, let me thank both of you. I've got to let you go, but let me thank both of you for what you do and really bringing to the attention to us the need to treat an injured mind as well as an injured body.
Happy to be here.
Yeah.
Thank you.
Thank you. Lovely to see both of you.
Thank you.
That's all we have time for today, but thank you very much. But join us tomorrow for World Health SocialGood, and tomorrow we'll bring you everything that happened today, and it's been quite a lot of activity. We've got the Ebola section for tomorrow. This is where we'll update you on what's the latest with the Ebola response. We'll be talking to the Secretary General's Special Representative for Ebola, We're going to be talking about what the organization is doing to reform so that it can respond to future type situations in a better way. We'll be talking about some of the comments that the Director General made in her speech yesterday, where she listed the 5 things that the organization would be doing. We're going to be talking about what it's going to take to move the progress forward in the countries that have been most intensely affected by Ebola. How do we get to zero? How do we move them forward into early recovery? This is a very exciting time to be working in public health. Also, we'll touch on progress in work on mothers, children, and adolescents. So that's what we've got for tomorrow on deck. It'll be a very packed agenda. Come with your questions, come with your chairs, stay a while, and we'll see you tomorrow on World Health Social Good. I'm Christy Feig in Geneva. Thanks for watching.